Good afternoon, everyone, and welcome to the first of our workshops on our integrated care system for the Black Country. I'm Jonathan Fellows. I'm the Chair Designate for the Black Country Integrated Care Board, and I'm joined today by Mark Axcell, who's the Interim Chief Executive Officer Designate for the Black Country Integrated Care Board. As I said, this is the first workshop that we've done, so it's a voyage of discovery for all of us. We're recording this session and we'll make it available afterwards on our website so that people that are unable to join us today can listen to the recording. If you have any questions that you want to raise during the workshop, please post them in the Q&A box. If possible, if you add your name, because then if we don't manage to answer all of these questions during the workshop, we can get back to you afterwards. But we'll also be making all the questions and the answers available on the website as well. So what we're going to cover today is a little bit about our system, about the ambition we have to improve health and care across the system, about some of the great work that took place in response to the COVID pandemic and the way that organisations really did collaborate and work together, a bit about how our integrated care system has developed so far, why it's different now and why it's going to increasingly become different to what's gone before, and then some of the next steps that we'll be undertaking. And then there'll be time, as I say, at the end, hopefully to answer all of the questions you may have. So let's start with our system. The Black Country's got a long history of manufacturing. I've heard it described as black by day and red by night, in reference to all the smoke and the fires of the ironworks and the mines. And the area's got an incredible heritage across all of its 4 proud boroughs of Dudley, Sandwell, Walsall and Wolverhampton. There are nearly 1.3 million people that live in the Black Country, but the industrial history plays a huge part in their lives. For many of them, they face shorter lifespans, more ill health and poorer quality of life than in the rest of England. So our integrated care partnership is designed to start making a difference to all of those inequalities by working together in different ways and across lots of organisations and sectors. If we can move on to the next slide, we list some of those groups. And I think it's important as well to recognise that whilst legislation is helpful in setting up the structures to enable that closer working to happen, it's the people in the system and the ambition that they have that's going to be key. And I'm sure everyone on this call will have examples of where things don't work well in the current system and that frustrate them, or will have ideas on how things could work better, but are not sure how to make that change happen. And that's about how we do things better by working together. And the key to all of this is that everyone recognises they can make a difference and they set out to do that. And in our ICS, we've set out the 3 key things that we want to achieve in order to improve health and well-being for the population of the Black Country. Firstly, we want to improve health and care services and make them focused on the patient being the most important factor in everything we do. We also want to train and develop the people that work in our system so that they can deliver the best health and care possible. We want to work with local authorities, with universities and colleges and with the voluntary organisations to attract more people to come and work in the Black Country. And finally, we need to recognise that not changing how we do things not only is the wrong thing for our patients and our population, it's also going to be unaffordable to carry on as we are. So we have to change how we do things. So now I'd like to hand over to Mark to take you through some of the plans we've got for improving health and care and for making that change. Thanks.
Good afternoon, everybody, and it's great to see so many people on the first of these workshops. I can see on my screen 280 attendees, so thank you so much for taking the time out in what are very busy times to join us to talk about hopefully the difference that we think the changes that are going to happen over the next few months and into the next few years will make to the people that matter most, which is people of the Black Country, be it our families, citizens, workforce. I think the first thing I'd like to say is we've already made a great start in some aspects of what we do. It's but we aren't always great at telling that story. So, for example, our mental health collaboration across the Black Country is delivering some really great improvements and strengthening what we do. I was looking at some performance figures this morning, and they are one of the best performing. We are one of the best performing systems in the Black Country, for example, for access to eating disorder services. And by focusing on the right balance of what we deliver for people in their neighbourhoods in the Black Country, as much as what do we need for a population the size of the Black Country, we can find the right balance in delivering care. We've got a world-class Black Country pathology service, which Lord Carter visited last year, and that's leading the way in many of the aspects of pathology delivery and is being looked upon nationally as a best practice model. And we know that testing and diagnostics are such an important part of what we need to provide if we are to ensure people get the right care in the right way as early as possible. Our acute trust colleagues across New Rural Wolverhampton, Walsall Healthcare, Sandwell and West Birmingham and Dudley Group are working closely together and have got an event, I think next Monday, another event to really engage clinicians in conversations about how we can share best practice, improve the journeys that patients go on and harness innovation in the way we deliver clinical care. But this partnership, the integrated care system, as Jonathan has said, is so much wider than that. And it was great a few weeks ago to attend one of the meetings of the Black Country Voluntary Sector Alliance, because we absolutely recognise the huge difference that the voluntary sector can make to people living well in their communities. And the voluntary sector is just huge across the Black Country, and we need to do more to be able to work more closely, both at a neighbourhood level and at a Black Country level with our voluntary sector partners, as well as our wider partners, if we are to deliver care for our service users, our population. And then, of course, you not being having to tell your story more than once is a huge part of this. So we've already moved to one record, or moving towards one care record across all of our partners in the Black Country, so that it saves you having to tell your story more than once, re-describe it, and actually we can see that continuity of care and the journey that patients and you may be on in terms of your care pathway, to make sure that it's supported, that the information that you've shared is passed on between organisations to make care as seamlessly as possible. And we'd like to share with you now an example on video of one of those. Actually, it's our Black Country Pathology service. So we'll play this video and then we'll pick up the discussion again.
Hello, my name's Dr. Paul Harrison. I'm the Clinical Director for the Black Country Pathology Services. For me, there are many reasons why setting up the Black Country Pathology Service has been the right thing to do. Obviously, there are some financial benefits from doing so, but for me, the real benefits are around the sort of services that we can develop for our patients and users. For me, probably the most important issue is about sustainability, and there's no doubt that having moved to develop the BCPS, we've been able to recruit staff in shortage specialties that we couldn't do before, and without doubt we've been able to cope with the COVID crisis in a way that would have just been impossible prior to BCPS. So to give you some idea, it's enabled us to move equipment around, move staff and other resources around to ensure each of our trusts within the BCPS partnership have had access to COVID-19 testing. This is something that just wouldn't have happened if we'd all been working as separate laboratories across our partner trusts. Another major area of benefit for the BCPS has been in successful recruitment. Prior to BCPS coming together, we had severe shortages in several specialties, especially cellular pathology. Since forming BCPS, we've been able to recruit a further 7 consultants in this area. That's really unprecedented in this time of national shortage. And again, I think this is because of the opportunities and the sustainability of the service that we can promise having come together. We've been able to implement a new laboratory information management system across the whole patch. This has got significant benefits going forward for the availability of results to our users, our medics, nurses, etc. across the whole area. This is again something that just couldn't have happened and wouldn't have happened if we hadn't decided to work together as a partnership. At BCPS, we've also been able to work on harmonising our equipment and testing across the whole Black Country and West Birmingham area. This has again got significant implications that will benefit our users and our patients in terms of standardisation of tests and indeed availability of tests that otherwise just wouldn't have occurred.
Thank you. For me, that was a great example, and Dr. Harrison covered a lot in a very short space of time there. And in there, he mentioned what we'll talk about a little bit later around how working as a system at a Black Country level has enabled us to respond to the challenges of the pandemic, enabled us to innovate, but also enabled us to support our workforce and be able to recruit. And as Jonathan has already said, one of our key areas of focus will be how do we as a health and care system in the Black Country become one of the best places to work. And you can see some examples there when you talk to staff and carers and volunteers. Actually what they say to us are probably a number of things. One is we need more of us because demand is rising, so absolutely. We want really good support for our well-being because the challenges that we are going through at the moment are unprecedented and will continue for some time yet. We want the best facilities around us, and we want to continue to improve the facilities in which we provide care in. And that as organisations, health and care organisations, that we're doing the right thing to support our staff who are members of our local communities. And what you'll see there is some examples where, for example, we are leading the way in overseas recruitment of nurses, attracting over 1,100 new nurses into the Black Country from overseas and leading the way in the Midlands in that work. Some of the work that's going on through Black Country Healthcare around improving adult mental health inpatient facilities, initially starting in Warsaw with the re-provision of Block Switch Hospital to Dorothy Patterson Hospital, but then longer term looking across the wider estate. Learning what we did in the pandemic around supporting staff in the challenges that they faced, where we set up a staff mental health helpline within a few days of the pandemic starting, but have grown that over time based on feedback from colleagues about more digital offers to be able to support well-being at work. And of course, we want our fantastic people, no matter what their background, to be treated equally and fairly in the way they do their job and they develop their careers. And organisations in our system and us as a system are doing more in particular around race and equality. And it was great to see that 3 organisations in our system have signed up to the local, so they've signed up to the Race Code, which is a national initiative to make sure that organisations, both in the way they support their staff, but also the way they make decisions, are tackling discrimination, which is something that all of us join together in wanting to tackle. But looking forward, we want to create more of those opportunities for people to develop. We want people to have long careers in health and care and be able to develop their careers and maybe go even further than that. And historically, people may have stayed in one area of care or healthcare, and maybe wanted to move across to a different part of health and care and found it challenging. That we want people to be able to develop their careers in the way they want to. That we recognise by the very fact that I'm talking to you like this today through a camera on a Microsoft Teams, that we keep some of that, and we recognise that there's a right balance between work and home lives, and that people can move more easily between organisations across our partnership. And what we want to do is ultimately, as Jonathan has said, for our system to be the very best place to work. When you take into account our volunteers, our carers, our care and healthcare staff, we are such a huge organisation or employer of people, and we want to work more widely with academic partners, with different employers across the Black Country, to really promote a career in health and care, why it's so rewarding, and why now more than ever it's the right time to make that step. Next slide, please. So I think for our next video, we're going to share with you and actually celebrate what is the bedrock of the NHS, which is our general practice. I've got no sound on this video.
I love working in general practice. I love the variety, I love the mixture of roles, I love the patient interaction that I have, the relationships that I have with other stakeholders. I'm able to help support patients with their long-term conditions, and it's a real privilege to have that one-to-one with people that you don't know, but be able to care for them.
There's such a variety working in general practice, but what I like about it is that you get to know the patients and the patients get to know you.
Our general practice is very rewarding for an AHP, I think, because I like the networking with the wider team, such as working with GP colleagues, and it's also the opportunity for the AHP to see patients at a very early stage, and the clinical outcomes are very rewarding. So that's what I like about working in general practice.
I enjoy working in general practice because it's varied work, and it's interesting because you're dealing with things that you wouldn't normally do as a frontline paramedic, and it can be quite challenging at times. I enjoy being involved in the housebound and the care home patients, because it gives these patients the opportunity to receive care and treatment that they might not necessarily receive because they are in those settings. So it's nice to be able to help them as much as we can. Also, there's obviously opportunities to have career development and train to become a first contact practitioner and then advanced practitioner, and also do non-medical prescribing.
Being a part of the process of increasing patients' confidence, empowering them and helping them to gain confidence is a great feeling, but also hearing the words, I am so glad I have someone to talk to, I don't feel so alone, that gives me the utmost job satisfaction. I really love to see the patients in their own environment because often they're more comfortable and at ease, and it's good to build relationships with their family members who are also involved in their care.
I think for me it's working within the wider MDT. Coming from the private sector and the community sector, it's very rare that I would have access to all these different clinicians, and also rare that I'd see a GP face to face. Often it's over the phone. So I think it's nice to be able to build these relationships face to face. If patients have concerns, I can go and speak to lots of different specialities. I can speak to the physiotherapist, I can speak to the OT, I can speak to the practice nurse, and it's just nice to be part of that wider team and working in that environment. It's rare, and hopefully it upskills me because I'll become more knowledgeable on what is available in the area and different conditions as well.
I think the most important thing about working in general practice is helping people. It's a very major part of the role, and what I enjoy the most is to be involved in the care of a patient from birth right to the end of life. So what I like about our team is that we're all like-minded individuals who have patients as the focus of our role.
I chose to work in general practice because I really enjoy the relationships you can have with your patients and the continuity of care. I really enjoy the variety it offers, that we can do specialty clinics like gynecology, cardiology, minor surgery. And I really like it that it is a family. You have all these different professions that all come together and all pulling in the right direction. And as a PA, that's invaluable, having people, who support you in your role. And for me, it was about the variety as well. I think we're exposed to a lot of conditions in general practice, which helps keep me as a generalist, as a physician associate as well, but also keeps it interesting for me. No day is the same.
Thank you, and apologies about the sound on the first play of that video, but for me the video really brought through the power of neighbourhoods and the incredible strong presence that primary care has in people's lives. And you may have heard in the video the acronym MDT used, which stands for multidisciplinary team, and that's exactly what primary care do. They bring people together in their neighbourhoods from all of the different organisations to support patients and families, and GPs and primary care will know as much about an individual, their family, because quite often they're on the same practice list, but also the communities in which they're delivering care. And I thought that video brought that through fantastically. Thank you. As Jonathan has already said, one of our main priorities as an ICS when we form on the 1st of July is to really work together, be it neighbourhood level, place level, our 4 boroughs of the Black Country, or a Black Country level, to prevent ill health and reduce the inequalities that we know our population face. And on the screen there, you've got some great examples of things that we've already started to work on. Some of those were brought home to us by the pandemic, which I will talk about in a moment. Others have been brought about by innovation at a local level that we've learned from and grown across the Black Country. And others have been brought about by attracting funding from not just health and care, but wider government investment, because we know that to deliver on ill health and reduce inequalities, our partnership needs to be so much wider than just health and care. So, for example, the one at the top around the partnership to host a new service for people to find and retain employment across the West Midlands was a partnership that was funded not by health and care, it was funded by another government department through the West Midlands Combined Authority. And the Thriving to Work programme, which was piloted in Dudley and Walsall between the 1st of June 2018 and October 2020, helped over 500 people to find employment. And we know that employment and the benefits that can bring, the difference it can make to a person's mental health and their physical health and their ability to live an independent life. And it's great in that example that we've been able to roll that pilot across to both Wolverhampton, Sandwell and West Birmingham. And I know that the pilot is looking to be extended because it's making a huge difference. But equally, it's about the contributions of all partners, as you can see on that slide. If you look at some of the voluntary sector investment, £1.2 million worth of funding, you look at some of the care navigation work that's gone on, the green agenda, all of it points to 4 things really. One is about aiming and to support people in living a healthier life for longer, that we tackle the wider determinants of health that creates such poor outcomes for parts of our system, that we have more personalised care in the way we approach care. It builds on the slide I said before about telling your story once, that it's more coordinated, but it's more relevant to your circumstances and the circumstances in which you live your life. That we learn a lot from the pandemic in making sure that if you want to, that you have access to more digital solutions for care. Many of you will have the COVID-19 app or the NHS app on your phones, and that's a great example of developments that we've seen through COVID that we would want to keep. But we have to give people the skills to be able to use digital more, to be able to access that care, and that people have opportunities for healthy life choices. So this isn't just about tackling ill health and poor care. This is about giving positive opportunities for people to take healthy life choices in the way they live their lives. Next slide, please. But as we move into 2022 and we start to think about what our system looks like in the future, it's important that we take the learning from what has been for all of us the most challenging 2 years, and it is nearly 2 years. I think in 2 weeks' time it'll be 2 years since the first national lockdown happened, which was around the middle of March, and that we take the learning. And I've had, although it's been challenging, the privilege to sit in many meetings where I've seen partners coming together in exceptional circumstances to make sure that we can provide support to residents, provide support to our staff, and to deliver the most exceptional ask as we've gone through the pandemic. And for me, this programme really defined what we can do best as a system if we want to, if we work in the right way, we role model the right behaviours, we be curious and work together as partners, what we potentially could achieve for our population. The examples on that slide are wide ranging, from the rollout of the vaccine programme, where we saw vaccine centres mobilised, sometimes within hours or days, across all of our boroughs. And the example there in the top left-hand corner was the Manda Centre. And the very first vaccine centres were literally set up within a few days and had to learn as they went in terms of how they developed and how they delivered the vaccine, but have continued to grow, learn from each other. You know, the Manda Centre in Wolverhampton, I'm sure, will have taken learning from the Sadler's Centre in Walsall. So it's about learning as much as it is being able to work together to be able to deliver care. Examples of obviously reaching out to care homes, residents, our COVID-19 community champions who worked with populations and communities right across the Black Country to support making sure they access the right care, they had the right support, to share messages and information to support them in the decisions they made around both the vaccine and the care they received through the pandemic. To our huge volunteer programme, and Dudley Group ran the volunteer bank for the vaccine programme. And one of the things that I think it's really important is that, well, firstly, we thank our volunteers for everything they've done over the last 2 years. But many of those volunteers would probably have never volunteered in the NHS or care environment before. And it's really important that we offer them more opportunities to do that as we go forward. So huge examples of when we do come together at a Black Country, we can be strong in the way we deliver care and improve outcomes. Next slide, please. And this is just a snapshot of the difference we've made. These are real people from across the Black Country who've received their COVID-19 vaccine and the people that supported them to make it happen. And this is, for me, the bit that brings it home, the difference that's been made in every corner of our system, be it medical staff in vaccination centres, local GPs going out of their way to support local care homes or local communities, that huge volunteer army I described that supported local people. From the point you went into the vaccine centre and you were directed which direction to go throughout the process. And our COVID-19 community champions who just know our communities so well and reached out to those communities, but even went out with the vaccine bus that we had as a system to make sure that people had access to the care that they need. Next slide, please. Next slide. As I've said, our response to the COVID-19 pandemic has seen our health and care services work together like never before, I would suggest. Our GPs and local authorities and community and voluntary groups join forces both at local neighbourhood level to make sure that the most vulnerable are getting the support that they need, but equally work together at a Black Country level when it needed that population level to be given that support. Our hospitals have worked together to make sure that they can continue to not only provide care for patients with COVID, but continue to provide care no matter what the condition that people are presenting with. So they've shared resources, supported staff, find new ways of working and ensuring that the care is continued to be provided for COVID-19 patients and for those needing other care and treatments. Our community, voluntary and social enterprise sector have been there to reduce isolation, tackle loneliness and keep people connected. And our vital care sector has provided essential care in homes across the region when people needed it most. And really that is what our health and care bill is about. It's about strengthening partnership working, breaking down barriers. COVID-19 has shown that we can do that. And now we need to build on it because we know it delivers better outcomes for our population. Next slide, please. So we've talked, we've built to it, we explained some of the examples we've done already around how we're working together in partnership. Jonathan has explained what we're trying to achieve. But we're going to go through a change now in terms of integrated care systems, integrated care boards and integrated partnerships. And what the next section does is aim to explain some of that in more detail for you. So we will be known as an integrated care system, and our partnerships will be between the organisations that meet health and care needs across our organisation and to coordinate that. But it's not just about one organisation. I know we've got staff as well as patient representatives, service users on the call. And I think many of you'd say you probably want us to work in a more joined up way, almost like a single entity. And this video that we're about to present will explain more about what we're aiming to achieve.
What if there was a way to help people get the care and support they need without having to overcome the barriers that exist between the different parts of our health and care system? For example, between health and social care. What can we change so that our health and care system becomes even better at helping us all to stay healthy? This might mean health and care professionals acting earlier to prevent illness and working in partnership with other sectors to tackle some of the causes of ill health. For example, poor housing or unemployment. Access to joined-up care and support has been a challenge for many years. One of the lessons from COVID-19 is that people need support that is joined up across local councils, the NHS, and voluntary and community organisations. Our best outcomes have happened when organisations have collaborated, sharing resources and making decisions quickly to provide the support the local people need. Deeper collaboration between the NHS and local councils is already becoming a reality across many parts of England. We are creating 42 health and care systems across the country, known as integrated care systems. They bring together professionals from a broad range of organisations to find and deliver the best way to support people in their local communities. They are joining up budgets, which means they can invest in services to meet the specific needs of the places they serve. Practical improvements have been made to people's lives, thanks to more convenient and personalised care and closer coordination of different services. During the COVID-19 pandemic, GPs, councils and charities joined forces to help quickly identify and support those at greater risk from the virus. People sleeping rough were given good accommodation with care and support around the clock. And hospitals worked together, sharing staff and resources so that everyone could get the help and care they needed. Integrated care systems will embed collaboration and help the NHS and local councils respond to the challenges we face beyond COVID. We want to make them as strong and effective as possible in every part of England. As needs change, with more people living into older age and with long-term conditions, we will need to continue to adapt the way we organise care. And by working as partners with a shared ambition to help our communities thrive, we achieve the best for everyone.
Thank you. So these proposals actually started in February 2021, so 1 year into the pandemic that we're now into. And the Health and Social Care Secretary at the time, with the support of NHS England and many of us across systems, really set out new proposals that, as I've said, wanted to build on the learning and the successful response to the pandemic that have been seen so far. So the government detailed in a white paper their plans for how they aim to bring health and care services closer together, improve and care and tackle health inequalities that we know COVID, the pandemic, shone a light on for, hopefully, as we make these changes, positive reasons as we make improvements. These measures will bring the legal framework, because there has to be a legal framework to all that we do, up to date to make health and care systems work more closely together, that they're fit for the future, and that they put in place target improvements that don't just focus on health or focus on care, because our population has told us they want it to be as one, and that we really target in on the improvements that our public tell us they want to see made around health, care, wider determinants of health, and in terms of decisions around good health. And it's also about continuing to do what we do, because there's still a day job in delivering health So making sure that as systems we continue to deliver high quality care across the Black Country, that we reduce bureaucracy, that we make ourselves more accountable and more joined up in the way we make decisions, the way we deliver care, the way we respond to the public around our performance. And the aim is that by bringing local government, the NHS and partners together, we can take the learning from the pandemic, operate in a seamless way, and really tackle what I think people want us to do, which is to tackle the needs of communities and our population as a whole. Next slide, please. The white paper also proposed that wherever possible we should work at a place-based level, and that's really important to us as a Black Country system. We have to recognise the way people live their lives, the way they want to access care. And what we mean by place in the Black Country is the boroughs of the Black Country, so Sandwell, Walsall, Wolverhampton and Dudley, 4 local authorities. So that place level commissioning at an ICS will align geographically to local authority boundaries. And we know for some integrated care systems, including our own, that didn't always fit the geography of how these initial ICSs had been set up. So it was agreed that the West Birmingham part of our system will join the Birmingham and Solihull integrated care system. And subject to the whole health and care bill, which is currently going through Parliament at the moment, and I think there's some more activity on the health and care bill today, tomorrow, securing royal assent, the transfer of the West Birmingham place will take place on the 1st of July 2022. Obviously, this transfer date will ensure synergies with other boundary changes that are happening across the country, and there's a number in our region. And it does give us more time to ensure a smooth transition. And I think importantly for our staff, because we have to remember that whilst this will undoubtedly deliver benefits for our Black Country population, there are a group of staff, particularly in the CCG, that are going through another management of change. It will minimise the impact on staff. But we are working very closely with Birmingham partners in advance of the 1st of July to make sure that our GPs and our health and care partners on the West Birmingham side of the patch are working with our Birmingham colleagues closely, so that any plans that are implemented from the 1st of April, because the business year runs 1st of April to 31st of March, they are involved with, and they're already having discussions to make sure that for West Birmingham that they are part of discussions about health and care, how health and care is delivered in Birmingham. Next slide, thank you. So what does it mean for our system? Well, it means a wider partnership for me. And that for me is where the magic will happen if we get this right. So in the future, our ICS will include NHS organisations, councils and others, all working together to achieve our common vision of improving the health and well-being of people in the Black Country. And locally, our ICS will be known as the Black Country Integrated Care System. But underneath that, if you like, will be 2 parts to how we work as a system. The first will be a Black Country Integrated Care Board, and that's a new organisation to lead integration in the NHS, bringing together all those involved in planning and providing NHS services. So on the 1st of July, which is the planned date for this to happen, the Black Country and West Birmingham Clinical Commissioning Group will cease to be as an organisation, and its functions and responsibilities will transfer to the Black Country Integrated Care Board. And then also a Black Country Integrated Care Partnership will be established at a Black Country level by the NHS, local government and wider partners. And I think the next slide explains that. And if you can't see that on the screen, we will share these slides around. So what you've got in the green boxes at the top is the regulatory system that we work in, NHS England and the Care Quality Commission. You've then got that Black Country statutory ICS that I've described. And there you've got 2 boards working in partnership with each other and in some ways having shared membership. One very much focused on health delivery, care delivery, and the other then looking at the wider determinants. So the Integrated Care Board will be the one that's focused on the NHS functions, care delivery, allocating NHS budgets. But in the purple box, the integrated care partnerships role is to play that really significant role in wider health, public health, social care, the wider determinants of health. And for me, the ICP, when we get up and running, is where we can make huge differences and inroads, in my view, into some of the health inequalities and health differences we've already described. That partnership needs to involve housing, it needs to involve local authorities, the voluntary sector, the university sector. We've got the opportunity to work with so many partners with local businesses through the business consortium, because we know that for people to live healthy and meaningful lives, that all of those partnerships can make such a huge difference. And then underneath it, you'll see the different parts that those two boards will work with, be it provider collaboratives. I've described already how the acute trusts are working together. Our mental health and learning disability trust have two roles, one both in terms of within the Black Country to work as a lead provider, but also to work in partnership with other mental health and learning disability trusts across the West Midlands, where we think that West Midlands footprint would benefit our population. Our health and wellbeing boards of our local authorities, our partnerships at place. If you remember in the primary care video that we saw earlier on, one of the GPs talked about the MDT, the multidisciplinary team. We're really place-based partnerships in each of our boroughs are just that. It's the organisations working together at a borough level to coordinate care, work more closely together and to deliver better outcomes for our population. And our primary care networks in each of our neighbourhoods, who are general practice, community pharmacists, dentists, opticians, many of which you'll know, many of which you'll be involved with, but we know that at neighbourhood level, that primary care network is really, really important to be able to coordinate care and for people having their first input and access into accessing care. Next slide, please. So the Integrated Care Board will be an NHS organisation that will replace the CCG, as I've said. It will adopt its statutory functions along with some of those from NHS England, and it will be responsible for the national legal requirements and functions, including allocation of and accounting for NHS resources, our staff, our workforce, etc. In the future, this Integrated Care Board will take on more responsibilities for primary care medical services, dental, optometry and pharmacy, because currently they are held at a regional level in terms of how they are commissioned and they need to be bought more locally. And it will take on more responsibility for specialised services. So specialised services tend to be those services that are very low volume but need really intensive care. And currently they are equally commissioned at a regional level, and we will be taking on some of the responsibility for those specialised services, either individually as an integrated care board or working in partnership with other integrated care boards, where we think that a wider population base is needed to develop that service. And I think we've already described what the ICB will be called. Next slide, please. And the ICP, the Black Country Integrated Care Partnership, will be formed by the Integrated Care Board and local authorities on the 1st of July. But we're already starting to talk with partners about how we operate that in shadow form, because we just want to get on with it. And actually, a lot of you have said, let's get on with it and deliver the change that you want to see. And we do currently have a partnership board, so that will replace that. And it will bring together, I hope, all of the partners that can make a difference to the Black Country in improving health and wellbeing. And what I will say is, whilst the legislation, the white paper, all of the things that are going on around us are important in terms of the legal aspects of what we need to achieve, it's probably more about the way we work and the culture of our system that's the most important to deliver the benefits that we want to take forward. Next slide, please. So what will be different? Next slide. Well, if you roll forward, what do we want to happen? We want people to live healthier for longer. We want care to be more coordinated to achieve that. And we want to make sure that, be it housing or be it population health, be it social care, be it health, be it voluntary sector, be it working with our employers across the Black Country, that we're doing everything we can to support that. That we recognise for a cohort of our population who are our most vulnerable that they may need to get extra support to stay healthy, and that extra support is well coordinated. That people have more opportunities for healthy life choices in the way they live their lives, and that we are making sure that we are investing our Black Country pound, our health and care pound, in mental health, primary and community health care services, particularly where that's about keeping people well in their communities and preventing them from needing a acute hospital inpatient bed or a mental health inpatient bed. That we're doing all we can to provide care in the community to keep people closer to their families. That care is personalised, you tell your story once, and that there are more digital options to be available to access care. And I know on the digital front, people have different views around how digital works in terms of healthcare, but I know some people have found it really beneficial to be able to access digital healthcare, and it's something we need to learn and embrace and look at and develop more. But at the same time, we have to make sure that people have access to digital devices across our communities, and that they have the skills to be able to use those digital devices to access their care. Next slide, please. We need to make the Black Country the best place to work. Our workforce are so important to us, and we want them to know that we care about them. We cannot deliver health and care without them. We wouldn't have got through the pandemic without them, and we want to make sure that we are supporting them as we move forward. That there's more opportunities for our workforce to develop, people to develop new skills, to think about maybe a different pathway in their career. And we definitely want more people from a more diverse background to come up into leadership roles and to ultimately replace Jonathan and I. You know, I've started off as an apprentice. I'd love it if an apprentice became chief exec one day, and we, particularly from a diverse background. There'll be more options to support workforce to balance home and working lives. That more ways for people to move around the system of health and care. Quite often people end up in quite linear career pathways because they've always trained in a certain way. Are you a physical health nurse or a mental health nurse is a great example. Is there dual training we could do? Can we multi-skill our future workforce to be able to develop their skills in a different way? Have we got the right roles to recognise the way we are moving forward in delivering care? Do we need to, for example, spend more on digital champions and developing digital trainers and looking at digital care as much as we are about enhancing and training our clinical workforce? How will our workforce get the support they need to do the job the best that they very can? Next slide, please. But most importantly, we want a system that is fit for the future, that localised teams of health and care work together in that MDT way that I described to support your social, physical and mental health, because we know that when you bring all of those together, we can improve healthy life expectancy, we can improve health outcomes. That you're supported to self-care. People want to live that independent life. They want to be able to access care in the right way for them. That our local hospitals, our local organisations are working together to innovate, to learn, to develop innovative ways of delivering care that continues to be safe and accessible. That we have the right amount of money to invest, and I think that's in two parts. One is about deciding what we need to do at scale, but also using our voice as a Black Country system to be able to attract inward investment. I talked about the Thrive programme that came through government investment, not through health or care, but actually came through the employment route, but is making a difference to health and care across the Black Country. And we want to make sure that wherever possible, we're investing more in frontline care services where it makes a true difference to people's long-term health and care needs and addresses inequalities. Next slide, please. So when there's change, there's an opportunity. And for me, there is a huge opportunity here. I describe it as a sweet spot really around partnership I think if you were to talk all the partners, which I have done since I came to role in November, I think that everybody realises that if we can work together in a more joined up way, in a way that focuses on our population, be it our workforce, our patients, our service users, the people we care for, our carers, that we can do more with the Black Country Pound that we have, that we can start to shine a light and really tackle some of those health inequalities that we see across the Black Country. These changes will happen in 2022, and this year will be a huge year in many ways. The Commonwealth Games is coming to Birmingham. Some of those events will be delivered in the Black Country. So never has there been a better time to focus on health and care across our system. But 2030 will be with us before we know it. For some of us, it doesn't seem like 5 minutes ago that we were talking about the millennium in 2000. And for me, the positivity I've seen around this change in terms of wanting to deliver in a different way to improve the outcomes for our workforce, who ultimately will improve the outcomes for our patients, our carers, our families, is just brilliant. And where we've got to create the time and the space is for people to be able to have the conversations that, if you're a member of staff on this call, I know you want to have. If you're a patient group, we'll want to have those conversations with you to engage you about how can we work differently and what partners do we need around the table if we truly are to make change to our people right across the Black Country. And I feel really passionate about that. And I think the will is there, the desire is there, but it's about the way we work, but also recognising that we're going to have to learn together. The health and care bill will happen, but how we work together, how we learn together, how we evolve together. And what I would say to people watching this is be curious, ask questions in the chat now, get involved with the future workshops we've had. You know, if you're a health and care professional, talk to your colleagues in other organisations about how you could work more closely together and the difference that you could make, or the things that you would like to change, and feed them back to us. Because what I'd like to do in 2030 is be celebrating a huge difference and reduction in health inequalities across the Black Country. But we can only do that if we work together. And I think I hand back to Jonathan at that point. Thank you.
Thanks, Mark. Right, so let's look at some of the next steps then for our system. Firstly, we're building the integrated care board that Mark described. I mentioned at the beginning, I've been appointed chair designate, so we'll take up the role from 1st of July when the ICB comes into being. Likewise, Mark is the CEO. We've recruited 5 independent non-executive directors. Alan Edwards, who will chair our audit committee for the system, Janjeet Hunjan, who will chair the finance, performance and digital committee, again for the system, Bishop Llewellyn Graham, who will have specific responsibility for looking at how we start to address inequality and inequity of access across our system. Ranjit Sondhi, who a number of you will know from his time at the CCG, who will head up the Remuneration and People Committee, and Dr. Sonia Ashraf, who will chair our Quality and Safety Committee. And we've also appointed to there are 3 mandated roles, 3 roles that have to be on the ICB board: a Chief Medical Officer, Chief Nursing Officer, and a Chief Finance Officer. We have appointed Dr. Ananta Dave as the Medical Officer. Some of you will know her. Probably a lot more of you will know Sally Roberts, who's been appointed as the Chief Nurse. And a number of you will know Tom Jackson from Dudley Group, who's been appointed as the Chief Finance Officer. So we've built the board. There are other roles still to fill on there, but you know, we're off to a good start, and the intention would be to be in a position by the 1st of April to be operating in shadow form, ready for the 1st of July, when hopefully the legislation comes into effect. And there are a number of future workshops that are building on this first one, giving people more chance to engage, to ask questions, to put forward their proposals for how we change things for the better. There are 2 more of these stakeholder workshops taking place. The first one on 24th of March to understand a bit more about the priorities that we're setting within our system, and then another one on the 19th of May, which is more focused on the proactive measures we'll take to improve health and care for local people. So again, I'd encourage as many of you as possible to talk to your colleagues, share ideas with them, and try and get as many people as possible involved in those workshops, because it's you that are going to make the difference to a number of these things in helping them happen. And in terms of how we work better with people and across communities and developing our strategy for that, there is a workshop taking place next week on the 9th of March. And again, that would be really helpful to hear from you about how you think we should best engage with you, with the communities that you work in, with the communities you live in, because clearly, we don't know everything. Some of us, I'm not sure, know anything, but clearly, we need to do this with your help and with your involvement. So we reach the bit where you get your opportunity to ask any questions that you've got or make any points. So this is the point where you get your big chance to say anything that's on your mind. So over to you. I can't see any questions yet in the chat, but
I've got some questions, Jonathan, if I run through them and then we'll pick them up. So thank you. We've had a lot of comments. So last call for questions. I'm going to start to scroll down them, please. The first one is from somebody anonymous, and I'm going to skip over some of the joining comments. So great to hear the voluntary sector is getting recognised with the Alliance. Yeah, fantastic work going on. Will they have a seat at the ICP or the ICB? Jonathan, do you want to take that one?
Yes, they will. They will definitely be involved in the Integrated Care Partnership, because they've got a huge role to play there, because NHS organisations know how to provide care, particularly general practice or acute services. But if we're going to start changing people's life determinants of health, then that's going to involve working with a lot of people who've got far more knowledge than we have about all those determinants. So yes, they will definitely have a seat.
Thank you. I can see a comment about, will the slides be circulated? And thank you, Charlotte, for answering that. Yes, we will share the slides alongside the live recording and Q&A on the Healthier Futures website. Another question, if you could pick one thing to be different for the way health and care work in the Black Country, what could it be? One thing, and I'm going to ask Jonathan, I'm going to give mine, I'll ask Jonathan to think about one as well. Without boundaries is, I think, the word I would use. That if you're a frontline health and care practitioner, you're a volunteer, no matter what your role, or you might even be working in housing or even in universities, and you're seeing somebody that needs that care, that you can access it readily, that it's joined up, and that we're tackling as much people's wider determinants of health, their mental and their physical health, in a more joined up way. Certainly examples when I've been out to primary care and general practice, when that MDT model has worked, and you talk about an individual and their family and the community they live in, works better than if you talk about an individual's physical health condition in one appointment, their potential wider social care needs in another appointment, or even their mental health needs in another appointment. It's how we join it up, and that's where the magic will happen, I think. Jonathan?
Yeah, for me, it's about how we value people and patients' time, and how we make sure that whatever it is that we're doing makes the best use of their time. And I think, it's not just putting the patient at the centre, it is asking that question, is this the right thing and the best thing to be doing for this patient? So I think it really, for me, is about putting that value front and centre.
Okay, thank you. Just looking through the other comments and questions, I can see somebody's put a comment about online repeat prescriptions, but I can see somebody's responded to that further down. What will be the effect on current jobs when we move to ICS? So there's no name to this. So if we're talking about clinical commissioning CCG staff, they will transfer across, Black Country staff will transfer across to the Black Country ICS, West Birmingham staff will transfer to the Birmingham ICS. And certainly at that change point, we're not expecting a huge amount of change. But if we are to achieve what I've just described and what Jonathan's just described to you, which is about working more closely, taking down organisational barriers, wanting to work in our neighbourhoods and our places, it's inevitable that we're going to see change for all of the ways we work going forward. So from a CCG staff perspective, I would expect there to be very little impact on jobs, but longer term, we're all going to have to change the way we work if we are to work in a more integrated way. How do we find out more about how the providers are working together in our system? There is an integrated, so there is an acute care collaboration newsletter. I'm not sure if it's on the Healthier Futures website, but I think we could share it on the website. So we'll make plans to do that, because actually it shares the great work that they're doing, and we should talk about it more openly. So if it's not already on the Healthier Futures website, we will add it onto there so that you can read it. So thank you. Claire, thank you for your question. The ICS sounds a positive step for health and care and social workers, families and communities. However, is there a robust tested ICT system that will support this so that swift, appropriate communication can take place? So you'll have heard us talk about the shared care record. That is not intended to replace any of the current systems that all of the different partner organisations operate. So I don't know whether your comment is about an individual system in an organisation, but certainly the aim of the shared care record is to pull the relevant information from each of the systems into one place, if you like, so that you can see quickly the information that you need, be it from care, be it from social care, be it from health, to enable you to track and support that patient. So it will, I think, be swifter than you've described in terms of sharing information, but there's no plan at this stage to have one single IT system for the whole of the ICS. How can organisations do something to contribute in support of the ICS's aspirations and alignment with the public health prevention agenda, connect with the ICS moving forward to be part of the conversations? Becky, that's a really great point. If I could ask one of the comms team just to reply to your question in the timeline, because we are going to be holding these kind of workshop events, but also some engagement events for voluntary sector, for example, patients, carers. So the opportunity to involve people as much as we possibly can in what we're trying to achieve. So if comms team could pop in Becky's question and email address if people want to get in touch, that'd be really helpful, please. Will you be offering jobs and trainings for neurodiverse staff to stay in employment or job share? We will be looking across all of our population and the challenges that they face and trying to make sure that wherever possible, we are offering employment, flexible roles, which are becoming increasingly more popular, because we want everybody really, no matter their health and care. So I'm sure we'll be picking that up for around neurodiversity, but actually it runs more widely than that. Angela, thank you to your response on prescribing. Thank you for that. How will the proposals in the integration white paper, particularly for an accountable care leader at place level, link into the relevant responsibility of the ICB, health and wellbeing boards and current place partnerships? So that the question is referring to the proposals that came out 2 weeks ago. in a white paper around integration, which really puts the primacy of delivery of care at a place level. And I think that's right. If we are to deliver the best outcomes for our population, to tackle health inequalities, then, you know, the work of the health and wellbeing boards and the ICB with those health and wellbeing boards is exactly where we'll make the most difference. So within the Black Country already, we have 4 place-based partnerships. We need to strengthen those partnerships. We need to make sure that the right partners are around the table. We need to make sure that it's got the right engagement with its population and it links well to its health and wellbeing board. And each of the 4 place-based partnerships across the Black Country are doing something slightly different. So they need to learn from each other in terms of sharing best practice and how they can support and develop. The actual detail of what that means to have an accountable leader at place level, we still need to work through. It's been just under 2 weeks since that paper come out. I've come from a meeting this morning where it's been discussed, and it's something that we still need to work through. But I know Jonathan and I are absolutely of one around places where we're going to make the most difference around population health and the difference to people in their neighbourhoods. So we are really keen to have those conversations over the coming weeks and months to work that through and work with our local authorities and their health and wellbeing boards. So thank you for that question. Amrik has asked if the video and presentation will be sent to us and they'll be shared on the website. Where will the Health Watch organisations across the Black Country sit, as in who will commission, monitor and who they will report to? I think that's a really good question and something we may need to take away, Jonathan, unless you've got an answer to that.
Yeah, I think so. I mean, clearly they'll be involved in the partnership and in the setting of the strategy for health and care across our system. But I think we need to look at, you know, where else they would best be used to fit in with us as well.
Question on, thank you for the positive comments around the integration, but quite rightly asking us if we're going to support NHS England's net zero NHS target. You're absolutely right, we can't separate healthy lifestyles in the Black Country without reducing climate change and aiming for net carbon. Yes, we are going to be doing more on that, and we've identified a leader in the Black Country, what we call a senior responsible officer, who will take forward that agenda for us. So as we start to develop our Black Country ICS, you'll hear us start to talk more about what we're planning to do and to get more people involved in those discussions. Lorraine, thank you for your question. To enable more investment into non-acute services and to achieve improved efficiency of resources, could the ICB force a merger of acute providers to reduce organisational and running costs, thus releasing funds for redeployment? So everybody I've spoken to, every leader across the Black Country absolutely wants to achieve that final statement, which is to release as much resource as possible for tackling health inequalities, creating the headroom to invest in innovation. But my experience, whenever you try and force a merger, is they fail. What you've got to want to do is do it for the right reasons, right strategic direction, be clear on what you're aiming to achieve for your workforce, your patients and your population. So we've already talked about the acute care collaboration, and we'll share the newsletter that's going on. Would we like to see our acute trusts working more closely together? Yes, we would, but I think that's a shared view that's shared by our acute trust colleagues. But certainly forcing a transaction would not be the right way to go, because then you'd kind of take the eye off the prize, which is improved health and care, maintaining the quality of services, supporting the workforce. But it's certainly something that in the future the acute providers may want to consider, and if they do consider that, then Jonathan and I and the ICB will be happy to receive that proposal. But it's not something we want to force at this stage. Let's just focus on how we can work together more closely. Do you believe that the workforce and public will be confused by the differentiation of the ICB and ICB? No, not only do they phonetically sound the same, but their roles will significantly overlap. I'd hope actually that we get to a place where the public wouldn't see a difference between the ICB and the ICP. That actually the ICB, whose role I've described, is around primarily commissioning health and care, and the wider partnership will be working closely together. So yes, I think it will be confusing to start with about exactly what is the responsibility of the ICB and the ICP. And yes, phonetically, the NHS and care sector loves its acronyms, but I would hope over time that they would significantly overlap. Deb, thank you for your question. When will this staff who are moving to BSOL be informed of this, as no information has been given? Could West Birmingham be kept as part of Black Country and West Birmingham? So on your second point, no. When the Act of Parliament goes through, that transfer will happen on the 1st of July. In terms of information given, I will pick that up off this call and make sure that if we haven't communicated yet to those staff that are impacted, that you have done. Deb, if you're a CCG member of staff, drop me an email just so I know who you are and I can respond to you directly to make sure that if we have sent out information and you haven't received it, that you're getting it. So just drop me an email. My email's in the address book. ICS, what's not to like? The big picture health in the UK in comparison to equivalent counterparts is notoriously chronically under-resourced, both financially and personal terms. How does the ICS bring about the meaningful and measurable improvement without the resources required? It's as I've just described. It's about creating headroom. It's about deciding the right things that we want to do at a population level, the size of the Black Country, how we can be more efficient in the way we do things, both clinical and non-clinical. The Black Country Pathology service is a great example that you saw at the start of that presentation. It's about having a stronger voice as a system to attract investment from outside of health and care, where we can make sure that it impacts and improves what we're doing for our population. So it's also about us being brave and taking risks in the way we invest in health and care going forward if we are to really tackle those inequalities. As wider systems, this has been tried before. 20 years ago, intermediate care working together in joint monies. Will this be any different this time round? I think there's a greater desire this time round to want to work more in partnership. I think that coming off the back of the pandemic, people have realised that to meet some of the challenges that we have to work together at a Black Country level. How will it need to be different this time? I think it is about how we work together, our partnerships, and be really clear what we want to work on at the Black Country level, what we want to work on at a place level in each borough, what we need to work on at a neighbourhood level. This is not about taking everything up to a Black Country footprint to deliver it, far from it, but it's about best population for best outcomes. And I think if we focus on that, then it will feel different this time round. What about environmental factors and the impact they have on the health in the Black Country? I think we've answered that. How will commissioning take place? As gaps in provision are identified, how can we ensure a diverse sector apply for the funding? We will make sure both through our place-based partnerships and that we do as an ICB that we are absolutely testing ourselves on that whole diversity aspect in the way we make decisions, both in terms of looking at how we stimulate the market and the people that we want to work with, how we make decisions around how we invest to support our population. So commissioning will take on that wider dimension around diversity that you've described. Thank you for the comment around diversity in the executives. Will there be more? More is needed. We are going to go through a recruitment process for 3 more execs. That will happen in the future. Certainly through the recruitment process, we are absolutely making sure that we are reaching out to as diverse a field of applicants as we possibly can. But even once we've made those appointments as an ICB, we will want to make sure that there's a pipeline of future leaders coming through that absolutely represents the population that we serve. So yes, it's great to see diversity in the executives that we've appointed now, but we need to maintain that and strengthen that in the future and make sure that no matter what your background, you have an opportunity to move up and take on a leadership role if you want to, and continue to progress your career. So it's one step in a lot of steps, if you like, to be able to improve that. Thank you to Charlotte for mentioning the workshops that are coming up. Thank you for that. Will there be investment into new roles to make us fit for the future? Since the CCG has merged into the Black Country, a lot of departments seemed under-resourced. Thank you for that comment. Certainly making sure that we have the right teams in the right places with doing the right roles will be a very important part of the ICB development. And for some teams that will feel very much the same as it does now. For others, undoubtedly, we'll need to change the way we do things, but certainly resource will be an important part of that. How will you help to explain these changes to our communities in an easily accessible way? Also, how will you generally involve local people, not just lip service, but genuine involvement and co-production? How we explain it is actually part of what we want to do. That actually one of my colleagues, Laura, is leading about how we engage communities. I think you'll see just above that question that Charlotte's posted an event we're holding on the 9th of March, 9:30 till 1:30, that will help us explore so many different ranges of engagement that we need to build with you and the communities that you represent. So in answer to your question, we want to build something that is meaningful to you as local people, but you need to work, we want you to work with us to be able to describe the best way to achieve that engagement, because if we look at it through our lens, it won't always be the right way to achieve it. So it feels meaningful, and that when we make decisions, you can understand the decisions we make, but as we develop services, innovate and transform services, that you're involved in that change. One of the areas that needs to be looked at when legislation prevents part of the public sector providing the support needed, such as housing for people with no recourse to funds. Thank you, Amrit, for that comment. How does DIHC fit with this? Surely the principles are the same. What is the difference? For those that don't know, DIHC is Dudley Integrated Health and Care Organisation in Dudley. And absolutely, DIHC's role within that particular place is to work closely with primary care and other partners. And what we'd expect to see is that kind of way of working developed across the Black Country. That doesn't necessarily mean that each place has to have a DIHC for that to happen, but the principles of partnership working is something that we'd want to see across all of them. Anthony, thank you for your comments. The presentations have highlighted proposals in the white paper and collaboration as key factors going forward. However, the different parts of the system continue to work on discrete regulatory paradigms, which can sometimes impede rather than facilitate the operationalisation of strategic alignment. It's, I think, right at the centre of the partnership environment. Is it more policy and regulation or a cultural shift that will lead to a greater overlap in the strategic diagram? Sorry, this sounds like an exam question, not meant to be, just interested in your thoughts. It's a great question. And for me, I think I said it, it's the way we do things that will be important. Yes, we may not be able to change in the regulatory paradigm that we work in, as you described it, Anthony, but if there's a willingness from partners right across the system to want to work together, then COVID has shown it's amazing what you can achieve and overcome in a short space of time, if that willingness and desire is there. What is the focus for development of children's and young people services in the borough, in the ICS? Thank you, Tim, for your question. So we will be looking at how we make sure that children's and young people has a really strong focus in the ICS. And I've been made aware this morning that as part of the development of the Integrated Care Board, we'll have to make sure that we have a named lead for children's and younger people. So that will be front and foremost in our thoughts. And then I'm just going to take one or two more questions because I'm conscious of time. I think we've talked about job security. I'm just looking at some other questions. Is there a patient public friendly explain changes in lay terms that could be shared? Thank you for that question. If we haven't got one, we'll start to develop one. Question around, obviously, so NHS and social care remaining under significant financial strain. Will organisations and ICBs equally share the burden of inevitable cost cutting? I think, will organisations and ICBs equally share the challenge of delivering population health investing in the right way, using our Black Country Pound in the most effective way. Yes, I would expect all the partners to the ICB to be involved in that decision making. Whether that leads to cost cutting, as you've just described, is a different discussion, but certainly how we use every Black Country Pound that we have to maximise health and care is absolutely the role of the ICB and all the partners around the table. Apologies if I'm skipping questions. Will ICS include all age ranges, including children's? Yes, it will. ICS board, it was mentioned that a few roles still need to be filled. Can you elaborate? We've still got to appoint to our Chief People Officer to deliver on that workforce priority that I've just described. We're going to have a Chief Equality and Innovation Officer to make sure that in everything we do, we are tackling health inequalities and we are harnessing innovation, both the innovation that goes on across our system, but more widely. And then obviously there is a CCG as a function still to run within the ICB, and we'll be recruiting a Chief Operating Officer to make sure that that function continues to run and develop. Will learning disabilities and autism ever be a service structure in its own right, instead of being bolted onto or additional to mental health? I think that's a really good question. Whilst organisationally we wouldn't want to see that change, we do in our system. It does have its own board, and we want to continue to have its own board, and I want to continue to have its own project structure and programme structure to make sure it has that independence. So thank you for that question. And I'm just going to pick one of the last few questions. Will we be co-locating and sharing office spaces with organisations in the NHS? I think that is a really great question. If we are to be true to the one of the things we said there about work and home balance, we've all got offices across our ICS. Wouldn't it be great if you lived in Sandwell that you could book an office in a Sandwell organisation rather than having to travel to, say, Dudley, for example? We aren't there yet, and it might take a while, but I think that's a great ambition for our staff to have. And a final question I'll take, is there a supporting organisational development programme that will enable the ICS to achieve ambition? Yes, there is. We're in the process of developing that at the moment, and it will be the same organisational development plan for our partners in our system as it will be for our CCG staff, so that we're developing both our ICB stroke CCG colleagues and our system partners in the same way, underpinned, as you described, Angela, by the shared values, behaviours and leadership. So thank you so much for all of those questions. I think we will capture them as well in future. But Jonathan, I think I'll hand back to you.
Smashing. Thanks, Mark. Well, thanks everyone for taking the time to be involved in this workshop. I hope you found it helpful, and I hope that it will start you thinking and talking about ways in which you can make a difference yourself, and also ways in which you can help us to identify how to make a difference to improve health and care for the people in the Black Country. So thanks everyone.